Hello, I'm Adam Bress, Associate Professor of Population Health Sciences at the University of Utah School of Medicine and Chair of the AHA Scientific Statement on the Management of Elevated Blood Pressure in the Acute Care Setting.
And I'm Chang, Professor of Medicine at Stanford University and co-chair of the upcoming statement.
We are delighted to be here with you today to discuss the upcoming statement, why the AHA commissioned this statement, and what are some of the key findings and takeaway messages. It was such an honor for me to co-chair the statement with you, Dr. Chang, and our esteemed group of incredible co-authors.
Thanks, Dr. Bress. Before we start our discussion, we would like to thank the AHA for commissioning this important and timely scientific statement and for their support throughout the entire process. So, what do you think led the AHA to decide to commission this statement?
Thanks, Tara. Elevated blood pressure in hospitalized patients is very common. And while there's a large body of evidence for managing high blood pressure in the outpatient setting, there's very little high-quality evidence and almost no randomized evidence to guide blood pressure management in the acute care setting. If there is a true hypertensive emergency, where there's not only very high blood pressure readings but also evidence of new or worsening target organ damage, there's no question that that needs to be treated promptly. But what to do about asymptomatic blood pressure elevations in the hospital is much less clear, especially since recent observational studies have shown potential harms associated with aggressive treatment in these situations, which we'll talk more about later.
Right. Asymptomatic elevated inpatient blood pressure is much more common than hypertensive emergencies and can actually affect upwards of 50 to 72% of hospitalizations. And though we lack good data to guide us, treatment with antihypertensive medications in these cases is really common. And the reasons for treating asymptomatic elevated inpatient blood pressures vary, but emotive terms like hypertensive crisis and hypertensive urgency could contribute. Health system factors also contribute, including responses to vital sign alarms, clinical decision alerts, and nursing notifications.
Exactly. And that's one of the reasons why we proposed changing the terminology in the statement. For example, for a hypertensive emergency, we mean blood pressure greater than 180 systolic or 110 to 120 diastolic with evidence of new or worsening target organ damage. That's unchanged, since, as you mentioned, this term is important because it indicates a need for urgent action. However, in the much more common scenario where there is no evidence of new target organ damage, we introduce new terms: asymptomatic markedly elevated inpatient blood pressure. This is for pressures above 180 systolic or 110 to 120 diastolic, and then also asymptomatic elevated inpatient blood pressure for readings that are above 130 over 80, to be consistent with the 2017 ACC AHA blood pressure guideline. We felt that these more neutral terms that remove the emotive language of crisis and urgency, which may promote unnecessary interventions.
It's also important to note that certain demographics are at higher risk for having asymptomatic inpatient blood pressure elevation, including older individuals, Black adults, and those with comorbidities such as diabetes, chronic kidney disease, and cardiovascular disease. Individuals who are socioeconomically disadvantaged, underinsured, or living in low-income areas are also at increased risk. Additionally, those who are non-adherent to antihypertensive medications are more likely to be hospitalized for hypertension-related issues.
Yeah, so these insights really do underscore the need for targeted interventions and perhaps more individualized strategies for populations that not only manage the underlying condition but also address the broader social determinants of health that really do substantially contribute to these risks.
So, Adam, earlier you touched on observational studies that showed potential harm with treating asymptomatic inpatient elevated blood pressure. Can you talk a little bit more about that now?
Yes. So first, Tara, we have no randomized trials or randomized evidence specifically in the population or the treatment of asymptomatic elevated inpatient blood pressure. So we need to rely on observational evidence. And one of the best observational studies was a recent target trial emulation study led by Tim Anderson, who also helped write the current statement. And he looked at 66,000 older hospitalized patients for non-cardiac reasons who had 2 or more elevated blood pressure readings in the first 48 hours of their hospitalization. And what they found was that patients that received early intensive blood pressure treatment during the first 48 hours, defined as receiving intravenous or new oral antihypertensive medications that they weren't taking prior to the admission, patients receiving intensive treatment were 28% more likely to experience adverse outcomes, such as death, acute kidney injury, myocardial injury, stroke, or being transferred to the ICU. And those that were treated with IV antihypertensive had even a greater risk of these adverse outcomes compared to standard treatment. And these results were consistent across a range of subgroups by age, baseline frailty status, pre-admission blood pressure readings, early hospital blood pressure readings, and with and without a history of cardiovascular disease.
And to add to that, a study led by Dr. Lamagazi, who also was a member of the statement's work group, looked retrospectively at 20,000 hospitalized adults who developed asymptomatic, markedly elevated blood pressure. Those treated with IV antihypertensive had a 60% greater risk of myocardial injury.
Yeah, those data are quite concerning, and it really does illustrate the potential risks of using IV antihypertensive medications without careful consideration. It really does highlight the need for judicious use.
Of course, while most patients may not require treatment for asymptomatic elevated inpatient blood pressure, there are circumstances where the benefit may outweigh the risks. For example, patients with persistently high blood pressure readings, specifically those over 180 to 110 over 120, might benefit from initiating or intensifying antihypertensive medications during the hospital stay. Treatment may also be reasonable for patients with persistently uncontrolled blood pressure in the outpatient setting, specifically those at high risk for or with a history of cardiovascular disease. However, it's important to remember that blood pressure may take several days to weeks to adjust to a medication change. Therefore, a typical inpatient stay may not be sufficient to fully assess the effects of a medication change, and close outpatient follow-up is going to be essential.
Yeah, that makes a lot of sense, Tara. And I would also add that the reason for the hospitalization could also impact treatment decisions. For example, patients with resistant hypertension. A hospital stay for a cardiac reason might be a really good time for a more comprehensive workup for secondary causes of hypertension. However, if the hospitalization is for a condition unrelated to hypertension or cardiovascular disease, such as a pneumonia, it might not be the best time to intervene, as the focus for that admission is probably best to address the acute process or illness, because their physiology might not be at baseline. It could alter their blood pressure readings in the hospital and also their response to blood pressure treatment.
So let's talk now about the actual management of elevated inpatient blood pressure. Our statement suggests several key steps, including proper blood pressure measurement technique with a device in good working order, assessing the severity, including an evaluation for target organ damage, identifying and addressing underlying causes, and a careful appraisal of the risks and benefits of initiating treatment for asymptomatic patients. In the meantime, the best available evidence would suggest a practical, common-sense approach. This includes repeating the blood pressure measurement using the correct technique with a recently calibrated device and addressing underlying contributors to the elevated blood pressure, such as pain, anxiety, and other illnesses, rather than focusing primarily on pharmacological interventions.
Absolutely. For this process, we've introduced a mnemonic in the statement. It's called AIM, or Assess, Identify, and Modify. So assess the reading, identify any new or worsening organ damage, and modify treatment accordingly. And for the post-hospitalization or discharge process, we've also kept the AIM acronym, but adapted it to arrange, inform, and monitor. Arrange follow-up care, inform patients and their caregivers about their condition and treatment, and monitor their progress. For some patients, the acute care setting may be an opportunity to set them on a path to long-term and durable blood pressure control. Since some patients may lack access to outpatient follow-up, strategies to increase post-discharge outpatient blood pressure care and monitoring are crucial and definitely will require pragmatic, patient-centered approaches.
Yeah, there's still a lot we don't know about asymptomatic inpatient elevated blood pressure. I think one thing in putting together this statement is that it really laid bare how much is still a question mark when it comes to treating asymptomatic inpatient elevated blood pressures. So what do you think are maybe the biggest gaps and the biggest areas that we would need to focus on?
I think one question is, among asymptomatic patients, is there ever a population in which IV antihypertensives are of any benefit? So one patient group would be markedly elevated, so people with pressures above 180 systolic or 110 to 120 diastolic without symptoms. what's the best management strategy there? Perhaps restarting home meds or allowing the acute process to play out. So having some guidance around that group, the asymptomatic, markedly elevated BP. And then I think targets, which blood pressure targets should we be thinking about in inpatients, particularly those with and without hypertension in the diagnosis of hypertension in the outpatient setting. Those are a few that come to my mind.
So I guess the final point is, what are the key takeaways for our audience today?
Sure. So I think some of the key takeaways, Tara, are a focus on measurement, both in terms of the device and that it's calibrated and in good working order, and measurement technique. And this includes everyone from MAs to nurses to other clinicians. And then also a really judicious and thoughtful approach to treating the readings themselves, focusing on underlying or reversible causes such as pain, anxiety, lack of sleep, and really having a high threshold for treating or changing antihypertensive medications in the hospital setting. I think the key takeaways are, as with everything in blood pressure, measurement is important. It really can create swings of 10 to sometimes 20 millimeters of mercury systolic. So really being careful about measurement and the quality of the device, and working with the hospital administration to really emphasize the importance that all the blood pressure measurement devices in the patient rooms are in good working order. Look for reversible causes, and for patients with asymptomatic, be very cautious with initiating new antihypertensive medications in the hospital, especially IV.
Yeah, and I would just add, in addition to having the right equipment, performing the blood pressure measurement correctly, it can be really hard in the inpatient setting, but I think we've all walked into the patient room where it's in some weird place, or, on the leg or things. And so really trying to make sure that the measurement was done correctly with the right device, as you mentioned. And then finally recognizing that there's still a lot we don't know, and encouraging folks like you and me and many of our colleagues on the writing committee to keep studying this and keep asking the questions and finding ways to try to get better answers.
Yeah, absolutely. And I think the last thing I'll add is, even if the medication regimen is not altered during the hospitalization, I do think it is always a key opportunity to share the information that was gathered in the hospital and in the discharge planning process, to give that to the outpatient clinicians so that they're aware and can develop a strategy to manage the potential either new diagnosis of hypertension or uncontrolled hypertension in the outpatient setting.
Yeah, definitely. Communication is like number 1, 2, and 3 for sure.
So in closing, we'd like to express our deep gratitude to the writing committee for their hard work and teamwork and dedication in developing this statement. And also, again, thanking the AHA for commissioning this timely and important statement. We encourage everyone to read the full statement. It is packed with detailed information that we believe can substantially enhance your understanding and management of elevated blood pressure in the hospital setting.
And on behalf of the writing committee, I'd like to first thank you, Adam, for leading this initiative, and we would like to thank all of you for taking the time to join us today.